Our BSN curriculum is one in which we've attempted to weave the concepts of evidence-based practice throughout. Today should simply be a review of many of the concepts you've been introduced to previously. The final goal of this course is for students to actively participate in the entire process of evidence-based practice with the coaching of faculty mentors. We'll provide you with formal evidence-based practice principles and tools to further develop the community health improvement project you began last semester. Our hope is that you can see how each problem you encounter in clinical practice will be one that you could potentially carry forward in this process once you graduate from our program. Every time we utilize evidence-based practice within the curriculum, we'll be showing you the 7 steps of EBP. This is to cement the process for you. We are going to circle back and we'll be going step by step in this course based on the steps as published by Melnick and Feinout-Overholt. The American Journal of Nursing articles are posted for you in your weekly modules, and these were written by these authors to demonstrate the steps of evidence-based practice. They'll be posted in the appropriate weeks, and you'll be asked to read those to gain insight into what the process looks like in practice. Today, we're going to talk about step 0, cultivating a spirit of inquiry within the environment. The evidence-based practice competencies, also developed by Melnick, Gallagher-Ford, and Feinout-Overholt in 2012, are found in your course documents module. There are competencies for practicing registered professional nurses, or RNs with an associate's or a bachelor's degree, and then advanced practice nurses. There has been an explosion of scientific evidence available to guide health professionals in their clinical decision making, but having evidence readily available for implementation doesn't make evidence-based care the norm still across the globe and in the United States especially, because clinicians lack the competency in evidence-based practice and cultures remain steeped in tradition. So the RN competencies include questioning practice for improving care, describing problems using internal evidence, formulating a PICO question, searching for external evidence, participating in critical appraisal of evidence, evaluating and synthesizing a body of evidence, collecting practice data, integrating evidence, implementing practice changes based on the evidence, clinical expertise, and patient preferences to improve care and outcomes, evaluating outcomes of decisions made by evidence-based practice initiatives, disseminating findings, and finally participating in strategies to sustain an evidence-based practice culture. You might recognize those competencies as things that you have been doing because we want you to continue doing them as you step into practice. This is figure 1.1 in your textbook, and it's the components of evidence-based practice. And you know these well, and I'll show you the slide that you have seen previously a little bit further on in this presentation. So external evidence, clinical expertise, patient preferences, and values. Those 3 components make up evidence-based clinical decision-making. External evidence includes evidence generated through rigorous research, systematic reviews, evidence-based theories, national benchmarks, opinion leaders, and expert panels. Clinical expertise, or internal evidence, is generated through things like practice initiatives, outcomes management, quality improvement projects, patient assessments and evaluations, and other resources within your organization. And then patient preferences and values come from family, from patients, from people who are having care done to them. All of these things are included in evidence-based clinical decision-making. So we want to define some terms because it's important that you understand differences between the concepts that we throw around. And we have done this before, but it bears doing again. So research is defined as the systematic, rigorous, logical investigation that aims to answer questions about nursing phenomena. So what kind of words do you think about when you think about research? Probably you think about variables, controls, groups, statistics. Research is done to test a hypothesis. It should be done to generate new knowledge that fills a knowledge gap. The thing about research results is that they're generalizable. So the project is done maybe on one area, but it's done in a way so that we can generalize those results across a broader group. Additionally, research usually requires an institutional review board review. Quality improvement is defined as the systematic use of data to monitor the outcomes of care processes, as well as the use of improvement methods to design and test changes in practice, the aim of which is to continuously improve the quality and safety of healthcare systems. So if you've been involved in quality improvement, you might have done things like chart reviews. You might have seen clinical guidelines posted, patient satisfaction surveys, utilization review. Quality improvement, or QI, usually is a systematic process done within an organization. They use models for quality improvement, like a Plan, Do, Study, Act, to identify and address issues within an organization. Quality improvement is really looking at structures and processes in the hospital to identify issues that are maybe preventing quality and or safety. So these things might surround patient falls, infections from catheters or from central lines, things like that. The thing about quality improvement is because it's in a specific institution, these results can't be generalized to a larger population. Additionally, quality improvement doesn't always require an institutional review board. And finally, evidence-based practice. So evidence-based practice is defined as the collection, interpretation, and integration of valid research evidence combined with clinical expertise and an understanding of patient and family values and preferences to inform clinical decision-making. Evidence-based practice is a decision-making process based on a body of evidence that has been identified already, critically appraised and synthesized. New knowledge might come about through implementation of evidence-based recommendations. Again, evidence-based practice isn't generalizable, but it could be transferable. So good practice founded on evidence can be used in different settings, right? Evidence-based practice can require submission to institutional review board, but that does vary. So you might think of terms like a literature review, clinical guidelines, patient satisfaction, patient safety, when you hear the term evidence-based practice. One of the main objectives within our curriculum is to ensure that students understand the differences between research, evidence-based practice, and quality improvement, because many working practitioners don't understand the differences. And the reason they don't is because many places are working on these different components maybe simultaneously. Not all hospitals will do research, but many will use pieces of research when doing quality improvement processes, calling it evidence-based practice. And we want to send you, young, excited new professionals, into practice, clearly understanding the difference here. So again, nursing research is done to generate new knowledge. When we do research utilization, maybe we're reading one piece of research and implementing those things into practice, but that is discouraged in evidence-based practice. With evidence-based practice, remember, we're gathering a large body of evidence and synthesizing all of that together. Quality improvement relies heavily on internal evidence and not necessarily a synthesis of external evidence. Again, they could be using pieces of research, but maybe not the whole picture. So we want students to understand that as a BSN prepared nurse, likely you're not going to be doing research. You may go into a teaching hospital where research is being done, and you should never be asked to do that without a mentor, somebody with a master's degree or a doctorate prepared to do research at your side. Additionally, please refrain from saying our research when you're talking about your projects in this course and at the symposium. Dina and I always make eye contact when we hear that, because our students truly aren't doing research, and you're not supposed to be doing research. That's not our job as a nurse. So translation of research into practice is TRIP. And this is the multifaceted systematic process of promoting adoption of evidence-based practices in the delivery of healthcare services. This goes beyond dissemination of evidence-based guidelines. Remember, evidence-based practice is the conscientious and judicious use of current best evidence in conjunction with clinical expertise, things that are happening on your unit or in your hospital, and the patient values, what patients you're taking care of, to guide healthcare decisions. The evidence-based practice movement was actually founded in the early 70s by Dr. Archie Cochrane. He was a British epidemiologist who struggled with the effectiveness of healthcare, and he challenged the public at that time to pay only for care that had been empirically supported as effective. Those are things that, it's taken decades to get this information into practice, making decisions that are based on research and not tradition or cost or what's convenient to us in any given facility. Again, this is figure 1-2 in your textbook, and it just talks about how evidence-based practice really should be an organizational culture and an environment, because combining the components of evidence-based practice when making clinical decisions enhances quality and patient outcomes. Additionally, it decreases costs. So the state of healthcare currently is fractured. The IOM report, To Err is Human, Building a Safer Health System, found that medical errors kill between 44,000 and 98,000 people in the United States each year in hospitals. If we use that lower estimate, 44,000, this means more people are dying from medical errors in a year than highway accidents, breast cancer, or AIDS. And that statistic is from 2010, and it has increased. Additionally, we have research on best practices, evidence-based processes that have been studied and implemented in facilities, and they aren't done in other facilities. One example, the author of our textbook, one of the authors, Bernadette Melnick, she created a system called COPE, COPE, for providing education to parents of newborns. And she found staggering statistics on how providing education decreased costs and improved outcomes for children, and people are not implementing this type of technique, even though it improves outcomes and saves millions of dollars. Research shows that evidence-based practice healthcare improves outcomes by at least 28 to 30%, and it reduces healthcare waste. The problem is that we are making do with what we have, and that increases our costs essentially. Additionally, there's geographic variation in the delivery of care, and evidence is evidence. What works in a city can work in a rural area, and especially when research and evidence has been involved. And so we need to start making consistent care, evidence-based consistent care, the standard or the norm in our culture. So evidence-based practice and the quadruple aim, really the triple aim was developed from the Institute of Healthcare Improvement originally, and it's changed to the quadruple aim. So the quadruple aim asks us to improve the patient experience, to improve outcomes, to reduce costs, and you're going to love this, improve clinician experience. So we want clinicians to find joy and fulfillment in their work. And so evidence-based practice is the way to get the quadruple aim in healthcare. Some key initiatives to advance evidence-based practice include the items listed on your slide here. The United States Preventative Service Task Force, Patient-Centered Outcomes Research Institute, the Helene Fold Health Trust National Institute for Evidence-Based Practice in Nursing and Healthcare. These initiatives have websites, and you can go to them for finding evidence-based practice information. The Institute of Medicine, now it's the NAM, Roundtable on Evidence-Based Medicine, asked that 90% of clinical decisions be supported by evidence by 2020. I couldn't find the most updated statistic, but definitely we have a long way to go in improving healthcare as far as making it evidence-based practice. Within healthcare organizations, there are barriers and facilitators that influence the uptake and sustainability of evidence-based practice. First of all, we need to be informed about what it is, and then learn how to overcome the barriers and leverage facilitators in order to implement it. Assess first. So we need to assess our organization, and we've done that here. Dina and myself have. We know that we have education to do for all faculty to be on board with evidence-based practice. When you go to your facilities to start your first jobs, you'll want to assess organizational barriers. What are facilitators? What's the culture in your practice area? And then are they ready to change the culture and do a system-wide implementation of evidence-based practice? So we can't make changes until we have cultures that support us making changes. And right now, it's easy to feel like we've had a setback with COVID because people are focused on other more pressing matters currently. So some of the examples of barriers and facilitators are listed on your slide. I mentioned the authors of your textbook did research to create the evidence-based practice competencies, and they continue to do research and to move evidence-based practice into nursing education across the globe. And I'll talk to you about that in class because we're using a lot of their resources. Research has been done on the things listed in this slide. So they did research on practitioners and said, what are barriers and what are facilitators? It's in the back of your textbook if you want to look at it there too. The thing is, we have to determine what can and cannot facilitate the implementation of evidence-based practice. Some institutional level things a good organization will have is a clear philosophy and vision about evidence-based practice being valued, expected, being the norm. We need to develop good facilities will have a strategic plan to create this culture and also have mentors, evidence-based practice mentors in place. Current barriers like lack of time and resources or misperceptions or negative attitudes about evidence-based practice still exist because in healthcare, we're doing more and more with less and less, right? Additionally, in healthcare, there's some resistance to change. And it's interesting, and probably because we have to change so often, but definitely that's a huge barrier to implementing evidence-based practice. Essentially, we want the nurse to be a knowledgeable consumer. Nurses must be knowledgeable consumers of research and be able to use critical appraisal skills to evaluate processes when reviewing research, so that they can determine the merit and readiness of research for use in clinical practice. Strategies to eliminate barriers to using evidence-based practice are largely institutional, but we hope that students leaving our program can be knowledgeable consumers and people who can make change happen in organizations. So we want you to leave our program with a spirit of inquiry. Essentially, the spirit of inquiry is you being willing to question practice that isn't evidence-based. And as a new nurse, you're gonna be focused on learning new things, but your eyes are fresh. You're gonna see things that maybe others can't see, and we want to encourage you to ask questions, ask why you're doing it a certain way, and seek to make changes. And so hopefully that's what we'll build in you throughout this semester. So because this is a virtual kind of on your own activity, you don't have to do it, but I posted an article. It says optional, but really awesome reading in the module underneath this recording. This is an article that's questioning clinical practice. So the thing is, knowledge in nursing is obtained through the ways on the slide here. And I talked to you about this probably J1 and J2. We get knowledge through traditions, through authority, and through borrowing, role modeling, and personal experience in nursing. So you watch us as faculty, you watch the nurses that you work with in the clinical setting, and you base your practice on what we're doing. It turns out we're not always doing the right thing. And so I want you to question all of us. I want you to question me. So this article that I'm talking about is Sacred Cows of Nursing Practice. And basically it's 20 questions. It talks about, is it evidence-based practice or is it a sacred cow? It includes things like patients experiencing hypotension and shock being put in the Trendelenburg position. How many times have I told you to do that in simulation? The article talks about scrubbing the hub of an IV port for a minimum of 15 seconds. Also taking the abdomen to ensure that a Dobhoff is put in the right location. Let's see, it talks about stopping enteral nutrition before a patient is repositioned. So all kinds of things. So if you have time, I'd love it if you got in and read that article, and then if you could skim through the article and then consider the evidence that you've been taught and what you've seen in a clinical setting. I would love it if you could get together as a team and talk about the article, because it is really interesting reading. And then I'm just going to wrap up the lecture today with some helpful websites. You have already accessed many of these websites leading up to this point in the program, and so they're probably not new resources for you, but we will be using some of them throughout this semester as well. So thank you for taking the time to listen to our first lecture, and I look forward to seeing you in class.